What if I told you that waking up 2, 3, sometimes 4 times a night to urinate is not a normal part of getting older? Most men I've spoken to over the years accept it like they accept gray hair. They assume the body just changes, that the bladder shrinks, that sleep gets lighter. That story is wrong. And the reason it matters is that believing it causes men to do nothing while a very specific biological process continues to accelerate inside the prostate. A process that, left unaddressed, does not plateau. It worsens. Here is what's actually happening. At this very moment, if you are a man over 55 who wakes in the night to urinate, there is a hormonal cascade taking place inside your prostate gland. A cascade that most appointments with a family doctor never address in any meaningful depth. Not because your doctor doesn't care, because the appointment is 15 minutes long and there are medications that manage the symptom. The mechanism behind the symptom rarely gets the attention it deserves. And here is what I find genuinely remarkable about this area of research. There is a class of compounds found in a handful of ordinary whole foods that operates on the exact same molecular target as two of the most commonly prescribed prostate drugs in the world, without their side effects. The research on this is not preliminary. It has been published in The Lancet and in peer-reviewed urology journals spanning 4 continents. And yet almost no one is talking about it. Today, I am going to walk you through exactly what is happening inside your prostate, the precise biological mechanism driving the symptoms you are experiencing, what the research says about a specific food-based protocol that targets that mechanism directly, and the exact protocol itself, the amounts, the timing, the preparation details, and the mistakes that will cost you most of the benefit. Hi, I'm Dr. Bennett. I spent years in clinical medicine watching patients manage the symptoms of prostate enlargement without anyone explaining why those symptoms were happening, what was driving the underlying process, or what the evidence said about non-pharmaceutical options. I started this channel to close that gap. What you are about to hear is grounded in peer-reviewed research, and I'll be specific about which studies, what their limitations are, and what we can reasonably conclude. I'll also be direct about the situations where you need a physician rather than a food protocol. Before we go further, a word on what this video is and is not. This is evidence-based educational content. It is not a substitute for a clinical evaluation. If you have not had your prostate assessed by a physician, that conversation needs to happen. If your symptoms are severe, difficulty initiating urination, inability to empty your bladder, blood in the urine, please see a doctor before implementing anything we discuss today. For men with mild to moderate symptoms who want to understand the biology and act on the evidence, this is for you. Here is what we're covering. First, I'll walk you through the specific hormonal and inflammatory mechanism driving prostate enlargement and nighttime urination. Second, I'll explain the food compounds that the research shows can interrupt that mechanism at the molecular level. Third, I'll give you the complete 30-day protocol, exact amounts, exact timing, exact preparation, and the common mistakes that eliminate the benefit. Quick note before we go deeper. I hear regularly from men who have watched several of these videos and never subscribed. If this kind of analysis is useful to you, take 2 seconds and check. It costs nothing, and it helps this information reach the men who need it most. Let me start with what actually causes an enlarged prostate, because most explanations I've seen stop at testosterone and leave out the part that matters most for intervention. The prostate, in a healthy young man, is roughly the size of a walnut. It sits directly below the bladder and wraps around the urethra, the tube through which urine leaves the body. When the prostate enlarges, as it does in over 50% of men by age 60 and in nearly 90% of men by age 80, it compresses the urethra from the outside. The result is reduced urinary flow, incomplete bladder emptying, and that familiar cycle of urgency, frequency, and nighttime interruptions that fragment sleep and erode quality of life. Now here is what most explanations miss. Testosterone itself is not the primary driver of prostate tissue overgrowth. The driver is a downstream metabolite of testosterone called dihydrotestosterone, or DHT. And the enzyme that converts testosterone into DHT is called 5-alpha reductase. Think of it this way. Testosterone circulating in the bloodstream is like raw fuel sitting in a tank. 5-alpha reductase is the converter. When it acts on testosterone inside prostate tissue, it produces DHT, which is approximately 5 times more potent than testosterone at activating androgen receptors in the prostate. DHT binds to those receptors and sends a signal that drives cell proliferation. Prostate tissue grows. Here is the piece that confuses many people. As men age, circulating testosterone actually declines, roughly 2 to 3% per year after age 35. You might expect that to mean less DHT activity and therefore less prostate growth. But the research documents something different. DHT levels within the prostate tissue itself remain largely stable even as serum testosterone falls. Why? Because 5-alpha reductase activity in the prostate tissue does not decline proportionally. The converter keeps running at significant capacity. The result is a prostate that is being continuously stimulated by DHT, even in the context of falling testosterone. And without intervention, prostate volume increases, the urethra compresses, and the symptoms progress. This is precisely why the pharmaceutical approach to BPH targets this enzyme directly. Finasteride inhibits type 2 5-alpha reductase. Dutasteride inhibits both type 1 and type 2. These drugs can reduce prostate volume meaningfully over time. They work. But the adverse event profile is real and documented. Decreased libido, impotence, and ejaculatory dysfunction occur in a clinically meaningful minority of men taking these drugs. For a man in his late 50s or 60s with an active life, those trade-offs are not trivial. Now, alongside the DHT cascade, there is a second mechanism that the research increasingly recognizes as relevant, and this one is almost never discussed in a standard appointment. It is chronic low-grade prostatic inflammation. The prostate of a man over 55 with BPH does not just enlarge. In a significant proportion of cases, it is also inflamed. Pro-inflammatory signaling within the tissue creates a microenvironment that promotes further cell proliferation and compounds the structural changes driven by DHT. Men with evidence of prostatic inflammation in biopsy samples have been shown to progress faster, higher rates of acute urinary retention, and more frequent need for surgical intervention than men with equivalent prostate volume but lower inflammatory burden. These two processes, the DHT accumulation via 5-alpha reductase and the chronic prostatic inflammation, are not independent. They feed each other. And both of them are targets that the food compounds I'm going to describe now can address simultaneously. Let me tell you about beta-sitosterol. This is the compound at the center of everything we're discussing today, and understanding its chemistry explains why the clinical results are what they are. Beta-sitosterol is a phytosterol, a plant-derived sterol, found concentrated in specific seeds and seed oils. At the molecular level, its structure is remarkably similar to cholesterol and to DHT itself. So similar, in fact, that researchers at the University of Massachusetts, Boston, published a detailed structural comparison in the American Journal of Clinical and Experimental Urology in 2023, noting that beta-sitosterol and finasteride share chemical resemblance to the very enzyme substrates and inhibitors they are both acting on. Beta-sitosterol competes with testosterone for binding at the 5-alpha reductase enzyme, partially blocking the conversion to DHT. It is not as potent as pharmaceutical inhibitors. I will be direct about that. But its documented effect on symptoms is real, clinically measurable, and achieved without the reproductive side effect profile that pharmaceutical drugs carry. The foundational human clinical trial on this was published in The Lancet in 1995 by Burgess and colleagues. This was a randomized, double-blind, placebo-controlled, multi-center study involving 200 men with symptomatic benign prostatic hyperplasia across multiple centers in Europe. Participants received 60 milligrams of beta-sitosterol daily in 3 divided doses or placebo for 6 months. The primary outcome was change in the modified Boyarsky symptom score. Secondary outcomes included the International Prostate Symptom Score, the validated questionnaire that measures urinary symptom severity, and objective urodynamic measures. The results were significant on multiple fronts. The beta-sitosterol group showed a 7.4-point reduction in International Prostate Symptom Score, compared to just 2.1 points in the placebo group. Peak urinary flow, the objective measure of how efficiently urine exits the body, increased from 9.9 milliliters per second to 15.2 milliliters per second in the beta-sitosterol group. That is a 53% improvement in peak flow. Residual urinary volume, the amount of urine left in the bladder after voiding, dropped from 65.8 milliliters at baseline to 30.4 milliliters. The placebo group showed no significant change in either of these measures, and the intervention was well tolerated with no serious adverse events reported. A subsequent systematic review published in the Cochrane database synthesized 4 randomized, placebo-controlled, double-blind trials involving 519 men, and found consistent evidence that beta-cytosterol preparations improve urinary symptom scores and flow measures in men with mild to moderate BPH. The weighted mean difference for the International Prostate Symptom Score was minus 4.9 points. That is a clinically meaningful reduction, beyond the minimum 3-point change a patient needs to perceive genuine improvement. Now, I want to be precise here because this is where I see health content get oversimplified. The beta-cytosterol in these trials was delivered as a concentrated, standardized preparation. The question of whether the same effect can be meaningfully achieved through whole food intake is the question that shapes the practical protocol. And the answer from the food-specific research is yes, when you choose the right food and consume it at adequate and consistent amounts. That food is cucurbita pepo, pumpkin seed. More specifically, cold-pressed pumpkin seed oil and whole pumpkin seeds. Pumpkin seed oil has a beta-cytosterol content that accounts for roughly 64% of its total sterol fraction. It is one of the most concentrated, naturally occurring food sources of this compound. And importantly, the researchers who have tested pumpkin seed in human clinical trials have done so not with extracts standardized to isolate beta-cytosterol, but with the whole seed and its oil, the full food matrix. The GRANU study, a randomized, placebo-controlled trial published in the European Journal of Urology, enrolled 1,431 men between the ages of 50 and 80 with confirmed BPH and lower urinary tract symptoms. Participants were assigned to whole pumpkin seed at 5 grams twice daily, pumpkin seed extract capsules, or placebo, for 12 months. At the end of 12 months, the pumpkin seed group had a clinically significant reduction in International Prostate Symptom Score in 58.5% of participants, compared to 47.3% in the placebo group. That 11-point difference in responder rate, sustained across 1,431 men over a full year, is not a trivial finding. It represents a meaningful proportion of men whose lives are meaningfully less interrupted at night. A separate randomized clinical trial published in BMC Urology directly compared pumpkin seed oil against tamsulosin, the alpha blocker most commonly prescribed for BPH symptoms. The trial included 73 men with BPH, average age 63. Both groups showed significant reductions in International Prostate Symptom Score over 3 months. By the final month, the reduction in symptom scores between the two groups was comparable. But here is the critical difference in outcomes. Not a single patient in the pumpkin seed oil group experienced a drug side effect. In the tamsulosin group, dizziness occurred in 5.9% of patients, headache in 2.9%, and retrograde ejaculation, where semen enters the bladder rather than exiting normally during orgasm, in another 2.9%. I want to be precise about the limitation here. Tamsulosin acted faster in the early weeks. It is an alpha blocker that relaxes smooth muscle in the prostate and bladder neck, which is a different mechanism than 5-alpha reductase inhibition. It provides quicker symptom relief, but it does not address the underlying hormonal process driving tissue growth. Beta-cytosterol and pumpkin seed act more slowly and on a different and arguably more fundamental target. These are not competing interventions. They are addressing different parts of the same problem. But for men seeking a food-based approach without pharmaceutical side effects, the pumpkin seed data is genuinely compelling. Now here is the second mechanism, and this is where pumpkin seeds become even more interesting. Remember the chronic prostatic inflammation I described earlier? Pumpkin seeds are rich in 2 additional compounds relevant to this pathway, zinc and linoleic acid. The prostate accumulates more zinc than any other organ in the body. Healthy prostate tissue maintains high intracellular zinc concentrations, and zinc has been shown to modulate inflammatory signaling pathways relevant to BPH. Research published in the Journal of Steroid Biochemistry showed that zinc at adequate tissue concentrations inhibits the binding of testosterone to the 5-alpha reductase enzyme, a second layer of the same enzymatic interference that beta-cytosterol provides. The combination within a single food is not incidental. It creates a synergistic effect at the same biological target through 2 distinct molecular mechanisms. A 28-gram serving of pumpkin seeds, roughly a small handful, delivers approximately 2 to 3 milligrams of zinc. A tablespoon of cold-pressed pumpkin seed oil delivers the concentrated sterol fraction without the fiber bulk, if that is the preferred format. Both are workable delivery vehicles for the protocol, and I'll give you the specific approach in a moment. There is a third mechanism worth understanding before we get to the protocol, because it explains why so many men with BPH are told their symptoms are normal, and then find that even when they start treatment, improvement is gradual. The prostate does not respond to hormonal signals the way a muscle responds to a stimulus. Tissue changes are slow. The mechanisms by which DHT drives cell proliferation play out over months and years, and the mechanisms by which you interrupt that process also play out over weeks and months. This is not a condition that responds in a week. The research timelines tell you that clearly. The Burgess Lancet trial measured outcomes at 6 months. The Granu study ran for 12 months. Expecting meaningful symptom change in 2 weeks is the expectation that causes men to abandon effective protocols. Now let me give you the exact protocol. Because the protocol matters, and there are specific decisions that will make the difference between consistency and abandonment. Priority 1 is cold-pressed pumpkin seed oil. This is the delivery mechanism with the most human clinical data and the highest concentration of the relevant compounds per serving. You want a cold-pressed, unrefined oil, not a refined or heat-processed oil, which degrades the sterol content. Cold-pressed pumpkin seed oil is dark green to dark brown in color, with a rich, nutty aroma. That color and aroma are indicators that the oil has not been stripped of its bioactive compounds. The dose used in the clinical literature is in the range of 500 to 1,000 milligrams of extract, which translates to approximately 1 tablespoon, around 14 to 15 milliliters, of cold-pressed pumpkin seed oil daily as a practical whole food equivalent. This is the dose I recommend as your starting point. Do not cook with pumpkin seed oil. Heat destroys the phytosterol fraction. Use it as a finishing oil. Pour it directly over food. Stir it into oatmeal. Add it to a smoothie. Take it off a spoon if that is simpler for you, but it should not go in a hot pan. The optimal timing is with a meal that contains some fat. Beta-sitosterol is a fat-soluble compound, and its absorption is significantly enhanced in the presence of dietary fat. A tablespoon of pumpkin seed oil with breakfast that already contains eggs, nuts, avocado, or any other fat-containing food is ideal. Do not take it on an empty stomach with water and nothing else. You will lose a significant portion of the bioavailability. Priority 2 is whole pumpkin seeds alongside the oil. The seeds add the zinc and the full spectrum of fatty acids that contribute to the anti-inflammatory pathway we discussed. A 28-gram serving of raw, unsalted pumpkin seeds once daily covers this component. That is roughly a small handful, or about 3 tablespoons of shelled seeds. They can be added to yogurt, to a salad, to a grain bowl, or eaten plain. The preparation detail that matters here is that raw or lightly roasted, at temperatures below 170 degrees Fahrenheit, preserves the sterol and fatty acid content better than high-heat roasting. Many commercially roasted pumpkin seeds are processed at temperatures that reduce the beneficial compound concentration. If you buy pre-roasted seeds, check that the label says lightly roasted. Raw is better. Heavily roasted and salted is the version to avoid. Priority 3 is consistency over 30 days before you evaluate. Here is why this timeline matters mechanically. The International Prostate Symptom Score changes in the Burgess trial were measured at week 4 and at 6 months. At week 4, there was already a measurable direction of change in the beta-sitosterol group, but the full separation between treatment and placebo in both symptom scores and urinary flow parameters was established at 6 months. The biology is responding to a sustained signal, not a single dose. 30 days gives you enough time to determine whether the protocol is moving in the right direction. A practical 30-day structure looks like this. With breakfast each morning, 1 tablespoon of cold-pressed pumpkin seed oil, taken with food that contains fat. At some point in the day, morning or afternoon, timing is flexible, 1 28-gram serving of raw or lightly roasted pumpkin seeds. That is the complete core protocol. 2 components, both obtained in any well-stocked grocery store, at a combined daily cost of roughly $1 or $2. Now let me share a few clinical observations that will help you execute this more effectively. The most common mistake I see is applying the protocol for 10 days, noticing nothing dramatic, and stopping. The biology does not cooperate with impatience here. What typically happens in the first 2 weeks is invisible. The sterol fraction begins competing at the enzymatic level, and the inflammatory burden begins to shift. The first subjective change most men report is not a reduction in urinary frequency per se, but a reduction in urgency. The feeling that you must get up immediately becomes somewhat less insistent. That typically precedes any measurable change in actual frequency. If you are tracking your symptoms at all, the urgency measure often moves before the frequency measure does. By weeks 3 through 4, men who are consistent with the protocol often report that the first interruption of the night is arriving later, that their initial uninterrupted sleep stretch is extending, even by 30 to 60 minutes. That is a functionally significant change, even though it might not appear dramatic on paper. By months 2 and 3, the men who have sustained the protocol report the changes that map to what the clinical trials measured: reduced number of nocturnal voids, stronger urinary stream, and reduced sense of incomplete emptying. One combination effect worth knowing about: pumpkin seed oil paired with the omega-3 fatty acids found in fatty fish, salmon, sardines, mackerel, addresses the inflammatory pathway through a complementary mechanism. The omega-3 fatty acids EPA and DHA directly reduce the pro-inflammatory cytokines that contribute to prostatic inflammation. If you eat fatty fish 2 or more times per week alongside the pumpkin seed protocol, you are covering both the hormonal and the inflammatory mechanisms simultaneously. That combination is the most complete dietary approach to this condition that the current evidence supports. The biggest mistake in terms of preparation is purchasing refined or flavored pumpkin seed oil sold as a culinary novelty. The quality of cold-pressed pumpkin seed oil matters. A reputable cold-pressed product will typically be sold in dark glass, amber or green, to protect the compounds from light degradation. It will have a visible best by date and will typically cost between $15 and $30 for a 250 milliliter bottle. If you are paying significantly less than that, ask questions about the processing method. Now let me be direct about safety parameters, because this is where responsible health content earns trust. Cold-pressed pumpkin seed oil and whole pumpkin seeds are extremely well tolerated in the vast majority of people. In the clinical trials we discussed, adverse events in the pumpkin seed groups were not reported at rates above placebo. This is one of the most benign dietary interventions in the literature. However, there are specific situations where you need to involve your physician before proceeding. If you are taking warfarin or any anticoagulant medication, inform your physician before significantly increasing your pumpkin seed oil intake, as the omega fatty acid content at higher doses can have a mild effect on bleeding parameters. If you have a nut or seed allergy, introduce this food carefully and monitor for any reaction, though true pumpkin seed allergy is uncommon. If you have active kidney disease and are on a fluid or protein restriction protocol, discuss dietary additions with your nephrologist. And importantly, this protocol is not a reason to defer a scheduled prostate evaluation. If you are due for a PSA test or a prostate exam and you have been postponing it, this video is not permission to continue postponing. A food protocol and clinical monitoring are not mutually exclusive. They should run in parallel. When should you seek medical attention promptly, regardless of this protocol? If you develop complete inability to urinate, if you notice blood in your urine, if you develop significant pain in the lower abdomen or pelvis, or if you experience fever alongside urinary symptoms, these warrant a same-day or urgent evaluation. These are not symptoms of BPH alone. They require clinical assessment. Let me now summarize what the research shows and what it means for you. The prostate does not enlarge randomly. It responds to a hormonal signal, DHT produced by the enzyme 5-alpha reductase, that the body cannot fully regulate on its own as the decades accumulate. That DHT-driven tissue growth compresses the urethra, reduces flow, increases residual volume, and creates the bladder urgency and frequency that breaks your sleep night after night. Chronic prostatic inflammation compounds and accelerates that process. These two mechanisms are the targets. Beta-sitosterol, found in concentrated form in cold-pressed pumpkin seed oil, competes with testosterone at the 5-alpha reductase enzyme, the same enzyme that pharmaceutical drugs like finasteride inhibit. Zinc, also abundant in pumpkin seeds, adds a second layer of interference at the same enzymatic target. The clinical evidence from a 200-patient Lancet trial, a 1,431-patient randomized study, a direct comparison against tamsulosin, and a systematic review synthesizing 519 patients across 4 trials shows consistently that beta-sitosterol preparations improve urinary symptom scores and urinary flow rates in men with mild to moderate BPH. The protocol is 1 tablespoon of cold-pressed pumpkin seed oil daily with a fat-containing meal, plus 1 small handful of raw or lightly roasted pumpkin seeds daily, sustained for a minimum of 30 days before evaluating direction of effect, and continued for at least 3 months for the full biological effect to express. Waking at 3 in the morning is not your destiny. It is a biological process with a documented mechanism, and that mechanism has documented, accessible, affordable targets. The men who remain in their best health as they age are not the ones with the best genetics. They are the ones who take the mechanism seriously and act on what the evidence actually says. If this kind of analysis is useful to you, please subscribe and give this video a like. In the next video, I'm going to cover the research on lycopene from cooked tomatoes and its documented effect on PSA levels and prostatic inflammation, the compound that has a Harvard cohort study of 47,000 men behind it. Leave a comment below with the symptom that bothers you most, whether it's the urgency, the interrupted sleep, the weak stream, or the incomplete emptying. I read everything, and what you tell me shapes what I research next. Keep investigating. I'll see you in the next one.